All right, welcome back, and we've got a case today for evaluation, and it's actually a good case to go over several different concepts. And the case was sent in by a recent attendee of our Ultimate 3D workshop, and it'll be an opportunity to review some of the key principles from the workshop. And it says, "Hi T-Bone, please review this case. Tooth number 10 has a mid-root fracture, and it appears there's some osseous defect labially. As much as I'd like to do an immediate, I think the labial bone is too compromised, and we should delay placement in 3 months with a screw retained temp. Any thoughts on strategy, implant position, grafting techniques? Should I order a CCAT guide and the implant and be prepared? Happy Thanksgiving and all of that." So obviously, right now this is after Thanksgiving. But I hope all is well with you, and let's kind of review. Let's review the case. So with any case, I always like to start by determining what type of surgical guide we're going to use, and we either have a analog workflow or a digital workflow. The difference between the two will be predicated on whether or not we will be able to get CEREC data into the software, into the system. And in this particular case, I look at this, and what I'm seeing is I'm seeing only 2 teeth that have a good chance of getting CEREC data in. All of these teeth right here have circumferential restorations on them, metallic restorations, which makes for a lot of scatter, which makes for bringing in the CEREC data a little bit more unpredictable. So, you know, part of me wants to say in a perfect world, this would be an analog case, but I would see if I could get the digital case in, digitally get it in. But what I would make sure of is that I have these 2 teeth in my CEREC data so that I can use that to get the data in. Now, what we did see in this particular case is that the data did come over, but we did not bring in these teeth right here to help us get a more accurate registration. But in reviewing the data, it does seem that our registration did work out in this particular case. Now, the challenge is that it's very difficult, as you can see right here, it's very difficult to see whether or not this is accurate because of this scatter right here, scatter right there, scatter right there, scatter right there, scatter right there. Just the general scatter makes it very difficult to determine whether or not the accuracy is there in terms of the integration. Now, with the digital workflow, the accuracy of your guide itself is solely predicated on how accurate your CEREC data integrates into your cone beam data. So it would have been nice in this particular case to have the teeth right here on from these teeth. But even here you can see there's significant amount of scatter on these teeth themselves also from the overall scatter right here. You can see scatter there and there where it becomes harder to see the outline of the teeth. So having looked at all of that, while we do look like we have a good, accurate integration of our cone beam data here, there's no way to know with 100% certainty how accurate it is. So that would lead me to want to use an analog workflow here. So one of the things that I want us to take hold in this video is that when we look in the mouth and we see all 2 circumferential restorations, I want us to start thinking analog workflow. And also when we see a few teeth that aren't circumferentially restored, then I want to make sure that we capture that in our CEREC data so that we can use that here. So depending on this case, as we look forward, I may consider having the patient back to have it scanned with a Sirona CCAT plate so I can go with the analog workflow. Now, next, what I would like to look at is the CEREC data. Now, typically with the immediate workflow, what I'm advocating and what we review in the workshop is planning our case like so, planning essentially a veneer on the front of the tooth only, not on the back, but just on the front. And typically I'll go ahead and draw my margin about 1 millimeter apical to the current restorative margin to accommodate for, to the current gingival margin, I should say, not restorative margin, to the current gingival margin to accommodate for any tissue loss from the trauma of extraction, bundle bone loss, and things of that nature. Here we can see that we've done a good job of drawing our restoration, but we didn't necessarily draw it 1 millimeter apical for any potential loss there. And the other thing in looking at this is that we went ahead and drew it as a crown and covered the lingual. Now, I'm assuming that the crown wasn't thin on the lingual and that we didn't need to add onto the lingual to get this into occlusion. So in a situation like this gives me a false sense of how lingual our restoration could be for final restoration, and which could mess with our screw retain positioning. I hope that makes sense in what I'm saying there, okay? So from that perspective, those are the things that we look at there. And now we're ready to go ahead and take a closer look at the surgical site. So what I've done is I've duplicated the plan. Let me remove all of this stuff here. So when I evaluate, I like to be able to evaluate from a clean view here. And we can see here what you're referring to in terms of potential damage to the buccal plate. It looks like right in there we may have a thin buccal plate there. So, you know, I can certainly see that. But from first glance right here, I still see this buccal plate intact. Certainly when we remove this, we curette this may find that there's a small dehiscence there. We can consider using an ice cream cone technique where once we extract, we can from the inside place a collagen membrane and pack bone in there to avoid that, to avoid having to raise a flap in that area. Or if there's a true dehiscence, then maybe we raise a flap. But as you know, as I go through this, I just want to get rid of some of these lines. But as I go through here, I'm still seeing that that buccal plate is intact all the way throughout. Certainly, it's thin. I'm not disagreeing there. It's definitely thin and definitely I'm going to need some management there. But I don't see any definitive break in the buccal plate as we're reviewing in the 360 view here. So based on that, my initial assessment would probably be to consider immediate placement, just making sure to manage not dehiscing that buccal plate, and then if we were to dehiss, and be prepared to graft and to maybe place a collagen membrane internally or even externally if necessary. So that's there. And now let's go ahead and place the implant that you had designed, and there's our implant. And my initial assessment on the implant based on this plan alone is going to be a couple of assessments here. One is we're quite thin right here based on the plan, and we're a little bit thin right here based on the plan. So I see quite a bit of room right here, and I see quite a bit of room right here. So more than likely I can see the reason that we put the implant in this position was to try to maintain a some semblance of coming through the incisal edge, or even trying to maintain a screw retain position, but sometimes we simply cannot do that. So in this particular case, I would probably choose to go somewhat like this, something along this line here. And this way now we have more room on the buccal here to manage. And then in evaluating this, I think stability should be a relatively not that difficult to achieve. If stability were a bit of a concern, I would consider going to a 13 millimeter implant here. And then that would, I think, certainly work here. And then the last thing I want to look at here also is that I still think we're a little bit mesial here. So I would probably just tilt this just a bit this way to get that a little bit better there. Now from there, I think now we're starting to look at a much more manageable position. And, you know, quite honestly, from here, I could see that we should be able to do an immediate. Unfortunately, we're not going to be able to do a chairside screw retained restoration, but we could certainly, with the Nobel implant, you use the angulated screw channel here and do an angulated screw channel through the laboratory. Now, I did want to point out to you from the original plan, here's the original plan as submitted. We can see that our plan right here, as we see it here, the implant is coming out quite a bit to the mesial and still coming out through the incisal edge. So screw retain wouldn't be possible there, so I wouldn't have, you know, gone so buccal right here. But again, looking at it from this view and the 3D view, this implant should probably be a little bit more centered like that, so that we're not coming through on the mesial there like so. Okay, so I'm going to go ahead and go back to my plan so that we can compare. And then in looking at this, we still have enough room to the adjacent roots, kind of like so. There we go. And like so. So I think this would lead me to a reasonable plan, a reasonable expectation for immediate placement, good tridimensional implant placement, and I would certainly consider immediate placement. I would consider an immediate provisional load to maintain the soft tissue. The provisional, I would mill chair side, have a screw hole access on the buccal, patch with composite. I would also go ahead and take a impression with a Nobel ELO scan, intraoral scan body, send that to the lab for a final screw retained angulated screw channel to be fabricated as well. So thank you again for submitting this case, and hopefully you found this very helpful, and I look forward to additional cases in the future.